We're going to look about how to take care of a person who's having surgery or has had surgery. So as a CNA, if you work in a hospital setting, you may be taking care of a person needing to go to surgery. If you're working in a nursing home, there's a good chance you're going to be taking care of people after surgeries that are there to actually rehab. So one of the things we learned back in Intro 1 is that many of our patients that are in a nursing home, it used to be patients that came to the nursing home or just patients that could no longer take care of themselves at home, and they were there and they were going to live there until they died. But now you have a lot of people that come there for rehabilitation. They come after a knee surgery, they come after a hip surgery, and then we take care of them and help them get stronger, be able to use that extremity better so they can go home and be independent again. Our goal is always going to be to help people become as independent as possible. So when we're looking at the person who's had surgery, one thing we need to realize with surgeries is the types of surgeries that happen. There's elective surgeries. Those are done by choice. So let's say, I don't know, you want a facelift. That would be an elective surgery. Or you trying to think what else could be an elective one for yourself. Something that is going to help maybe the appearance or even potentially with mobility, but it's not really necessary for life or for good health. Urgent surgeries are needed for the person's health. So let's say you have gallstones and you get these gallbladder attacks. Not a life and death thing unless the gallstone actually occludes the bile duct, but generally it makes you uncomfortable. It's going to impact your quality of life if you don't get it done. And so we're going to need to do it for the person's health, but we can schedule it. We can get the person, ready and prepared for it and give them a little bit of time to get things organized before they actually come in for surgery. Then there's emergency surgeries. Those are done at once to save someone's life. So let's say you have an appendicitis and the appendix is ruptured. That person needs emergency surgery right away as a life-saving measure. So elective, done by choice. Urgent, done for the person's health to improve quality of health. Emergency, done to save life or function. Now, as far as why people fear surgery, I don't know if you've ever had to have surgery, but the most common reason people complain of being afraid of having surgery is they're afraid of dying. Well, that's a big fear right there. But they're also afraid of waking up during surgery, of not actually being put to sleep, and then other people not being aware of it. So those are probably the two most common things that people will complain about. But they're also afraid of complications. Are they going to be disfigured, or are they going to have a disability from it? Pain. They're concerned about the pain that they're going to have after surgery. And as I mentioned, being awake or waking up during the surgery. So they're afraid of not waking up and dying, and then they're afraid of being awake as well. If they're going in because they're there for a tumor removal or something, they're always worried about, is it going to be cancerous? Is there going to be needed more treatments for themselves? I thought this was really cute. It says, Edith, after all the wounds heal and the bandages come off, your looks are going to improve, but you're still going to be a pig. So, sometimes even when we do opt for plastic surgeries, there's only so much people can do, right? So one thing that we'd like to do before a person goes from surgery, and this is whether you're in the hospital and they're going for surgery, or you're in the nursing home, you're going to send them over to the hospital for some type of procedure. One of the things we like to do is preoperative care, and that's the care before operation, preoperative, before operative care. And we like to teach them. We like to kind of let them know what to expect, just to kind of prepare them at what to expect during the procedure, what to expect when they get out of the procedure, so it's not so scary for them. So one of the things we teach them is deep breathing and coughing. So it is really important when a person has surgery and the person is put out under anesthesia, they are not taking deep breaths. They're laying there. The anesthesiologist may be breathing for them, actually pushing air into them, but they don't take nice deep breaths that get all the way down to those air sacs, all the way down in the lower lungs. And they're not doing nice forceful coughing, obviously, because they're asleep. So secretions can start building up. And that can predispose a person to pneumonias. So one of the things we always worry about after surgery for patients, especially our elderly population, is pneumonias. So teaching them to do proper deep breathing and coughing and how to use an incentive spirometer. Those are really, incentive spirometers is this machine right here that the person inhales air through. So they're not blowing air into it, they're actually inhaling through it. And they make a ball rise and they try to bring it up nice and slow and steady, but as far as they can, and it will promote air coming down deep into the lungs. Leg exercises. Another thing we always worry about after a surgical procedure is, again, the person's not moving. I mean, when you're sleeping, you're constantly moving. You constantly toss and turn and move your legs. That keeps blood clots from forming. When blood sits, when it pulls in one area, it can start to form a clot. So having the person move and exercise their legs after surgery, very important. We also might do those anti-embolic stockings, those compression socks we talked about when we were talking about also, wound care. So those are also really important to make sure that the person is not going to develop blood clots in their legs. A blood clot in the leg is called a thrombus, and then if that blood clot dislodges and moves to another area of the body, it's called an embolus. Vital signs. We like to get vital signs before they go for surgery so we can compare after they get back from surgery to make sure their vital signs are staying stable. And then turning and repositioning. We let them know we're going to be moving them a lot. It helps keep from getting pneumonias. It helps keep blood clots from happening. So it's really important that we get these people moving as soon as possible. And I know you might think, well, okay, after surgery, they need rest. They need, the tissues need to rest for growth and repair. We need to keep people moving. It used to be long ago, after a person had surgery, we would keep them on bed rest for a few days afterwards for just that thought, to have them rest. And we'd have very minimal activity, very minimal exercise, because we thought the more they rested, the better off they would heal. But then they started getting pneumonias and blood clots and having lots of complications. And so they found that, hey, the sooner we move people, the better off they're going to be. Early ambulation, get them up walking as soon as possible. Even our open heart surgery patients in the hospital, they go in for surgery that morning. By that afternoon, we've got them up in a chair. By the next morning, we're walking them, because the earlier they move, the better off they're going to be. We let them know they're going to have pain and what we're going to do about that pain. A lot of people that have pain after they have surgery, they will have what we call a PCA machine, a patient-controlled analgesic machine, where they can actually control their pain medication. So it's pain medication that goes in through their IV, and it has all these security locks on it, so they can only get so much pain medication every so often, so they can't overdose themselves on it. But they just have to hit a button. The pain medication is delivered right through their vein. It works very quickly, and that way they're not having to wait for the nurse, wait for somebody to go get them something, so they have much better pain management control. And then we usually always let them know what to expect as far as equipment and tubes. People are always, when we have surgery, they always have put an IV in them to give them medications through, the anesthetics, the medication, pain medicines. But are they going to have tubes? Are they going to have urinary tubes? Are they going to have oxygen tubing when they come back? Are they going to have chest tubes? So we always kind of want to prepare them for that as well. And then what kind of restrictions are going to happen because of the surgery? So these are things that if we can, we like to teach them before they go into surgery. Now, if it's a life and death situation, you show up in the emergency room, you're bleeding to death from an accident, we've got to rush you into surgery. I'm not worried about all this teaching. We've just got to get you stable. But ideally, especially for elective and urgent ones, we usually have time to get this teaching in. So usually before surgery, and of course this is going to depend on the person's age and their underlying health, but they usually like to get a chest x-ray just to make sure that there's nothing going on in the lungs, that they don't already have some kind of pneumonia or something starting before they do surgery. A CBC, that's a complete blood count, and they just want to check and make sure that their red blood cell count is good, that their white blood cell count that helps them fight infection is working okay. That they're not already showing that they have an infection in their blood. A urinalysis to make sure there's no urinary tract infection before they get started. And then for people that are usually around 50 and older, they usually get an ECG, which is an electrocardiogram, just to make sure the heart's functioning well before they do any kind of surgery. Other things to consider before surgery, as far as food and fluids go, they are usually NPO. That means non per aus, or nothing by mouth. So they're not allowed to eat or drink anything for a minimum of 8 hours. And depending on what kind of surgery is, if it's surgery to the abdomen area, they might be NPO for 12 hours. They might even be on clear liquids for a day or two and then NPO, because they really want that stomach emptied if they're doing surgery on that. So it will depend on what type of surgery as to how long they have to be NPO for, but at least 8 hours. Urinary elimination. We want them to go pee before they have to go off to surgery, or if they have a urinary catheter, we're going to empty that catheter. Bowel care. If they are having rectal surgery, they're going to do a bowel prep. They're going to want the bowels to be empty of bowel movement, so they might have you do an enema. Okay, they might have you do enemas until it's all cleared out, because they don't want to be dealing with stool in there if they're going to be operating in there. They want everything to stay as clean as possible. And then as far as personal care, usually before surgery, we give the person a bath. We have them remove makeup, let them brush their teeth. We don't like them to have dentures in when they go to surgery, so the dentures are removed for surgery. If they have a prosthetic leg or arm or something, that's taken off before surgery. They like them to wear elastic stockings. Now, these thromboembolic devices, we call them TED hose, thromboembolic device, or an anti-embolic stocking, or a compression sock. You'll hear them referred to as many things. They make them knee high and they make them thigh high. So what happens is it puts more pressure down at the ankle. It comes up lighter. There's still pressure on the calf, but a little bit lighter on the ankle, less as it goes over the knee, and then it'll come up again a little bit, and then less right up here at the thigh. So that's going to promote blood flow instead of just pulling in the lower legs, it's going to promote it to come back up. So the physician might order knee-high or thigh-high compression socks, and we can put those on. They usually have a hole over the top of the toes or on the bottom of the toes. And the sock still covers the toes, but this way you can actually, where the hole is, you can stretch it, move it over the toes, check the toes for circulation, and then put it back. You do want to make sure, these compression socks, sometimes they can be so tight they can cut off the circulation too much. Now, another type of compression stocking that they have is they have what we call sequential compression devices. It looks almost like a blood pressure cuff that wraps around the calf, and then it's hooked up to an air compressor, and it inflates and deflates and inflates and deflates. And while they're in the surgical procedure, they're on, and then after they come out of surgery until they're up walking around really well, they have them while they're in bed, and it just promotes blood flow and circulation to the legs, so it doesn't have time to develop blood clots. We also like them to remove their jewelry. If they won't remove it, like if they have a wedding ring, they won't remove it, then we usually tape it in place so it can't accidentally fall off. And then as far as skin preps go, we don't shave the hair anymore, we clip it. So we clean the skin and we clip the hair as close as we can. The reason they don't like you to shave hair anymore is because it's really easy to get tiny little nicks or tears in the skin. And then if that's where they're going to be doing surgery, you don't want, then you're already going to promote infection if there's little tiny skin tears in there. So they usually clip hair if the hair needs to be shaved. A consent form will have to be done. In a consent form, the physician has to explain what the procedure is, what the potential risks are, and then it's usually going to be the RN or the LVN that's going to sign that consent. And then there's a pre-op checklist, just a list of things that we want to make sure we've done before the patient. Will ask you, have they been cleaned up? Have the TED hose been on? Did you remove the jewelry? It just kind of goes through a list. How long have they been NPO for? It's just kind of a checklist that we go through before we send them off to surgery. So then they go to surgery and they're going to get anesthesia. So anesthesia is the loss of feeling or sensation produced by a drug. So it's giving a medication, giving a drug to produce a loss of sensation. And it could be a general anesthetic where they're just going to be knocked out. They're not going to be aware of anything. A regional anesthetic. So let's say a person who's delivering a baby and they have to have a C-section, but they want to be awake. They want to know when that baby's coming out. They might do a spinal anesthesia where it's going to numb them, from from above the waist down, but they'll still be awake, so they'll know when the baby's being born. So that would be a regional anesthetic or a local anesthetic. Think of when you get, like, if you get gone to the dentist and you've gotten tooth work done and they've numbed up a tooth, just that one tooth to work on it, that would be a local anesthetic. But it's given by an anesthesiologist or a nurse anesthetist. So after a person becomes an RN, they can actually go for continue more schooling and become a nurse anesthetist, where they actually do the anesthesia for surgeries. So the person has the surgery, and then after surgery, they go to what we call the PACU room. It's the post-acute care, post-anesthesia care unit. Sorry, post-anesthesia care unit. And they usually go there for 1 to 2 hours until their vital signs are stable and they're starting to wake up from the anesthesia, and then they can go back to the room at the hospital. So you would help prepare the room. When they come back to their room, you're going to be doing vital signs and observations very frequently. So generally, after a person comes back to their room after surgery, we do vital signs: blood pressure, pulse, respirations. You're going to get a temperature, check their pain level, and you're going to do that every 15 minutes for 4 times. So for the first hour, you're checking them every 15 minutes. And you also want to observe the area where the surgery was. Is it bleeding? Okay, does it look like there's any problem? Are they having any problems breathing? Is there anything that looks off to you? So we do vital signs every 15 minutes for 4 times, then every 30 minutes for 4 times, and then every hour for 4 times. And then if everything's going okay, every 4 hours is okay. We're also going to help with positioning and leg exercises. We need to get those legs moving. It's going to prevent blood clots. And we said a blood clot is called a thrombus. And if that thrombus breaks off, so if you have a blood clot develop in the legs and then it breaks, it detaches off the leg and it travels through the body, the 2 most common places that a blood clot's going to go to is the lungs, and that's called a pulmonary emboli, or up into the brain, and they're going to have an embolic stroke. So we really want to prevent this from happening. So thrombus is a blood clot, embolus is a traveling blood clot, and by repositioning them and moving them and getting their legs moving and getting them up early to move and to walk and to do range of motion, and then those anti-embolic stockings, or if they can't tolerate the stockings, sometimes we use elastic bandages. There's also those sequential compression devices. Like I said, it kind of looks like a blood pressure, wraps around the leg, and then it's attached to an air compressor, and it just pumps up with air and it deflates, and it pumps up with air and it deflates, and it pumps up with air and it deflates. It just constantly does that the whole time they're in bed. Coughing and deep breathing exercises, and that incentive spirometer to prevent atelectasis and pneumonias. Now, atelectasis is the collapse of those alveoli. So those alveoli, those little air sacs in the lungs, when a person isn't taking deep breaths, they're not able to cough, and they're getting, what happens is those air sacs down in the lower lungs, they actually collapse, and then they don't move air in and out of them, and then the person, it's going to make them more prone to catching a pneumonia. So we want them to cough, we want them to deep breathe, we want them to use that incentive spirometer. And usually after surgery, we have them do this every hour while they're awake, every hour while awake. Nutrition and fluids. So as soon as they're fully wake up after surgery, and if they're not nauseated, some people get really nauseous after anesthesia, some people don't, but after they're fully awake, depending on what kind of surgery they had, if they had surgery to their stomach, they may not be getting food yet, but for most things, they'll be able to start eating and drinking, and we usually start them with just some liquids and soft foods that aren't really going to upset their stomach much. We need to make sure after surgery that they're eliminating okay, that they're able to go to the bathroom. And then we're also going to be helping them with pain control management. So whether they're using that PCA, that patient-controlled analgesic machine, or whether or not the nurse is bringing them pain medication, also repositioning them for comfort, making sure their linens aren't wrinkled up underneath them. All of those things are going to be beneficial. So we will stop there.